Okay, well, I'll get started. Welcome, everybody. Just getting things set up here from a technical standpoint. We have quite a few in the room here in Edmonton at U of A, and of course, we have a ton online, which is good to see everybody. Starting off this series, we have monthly ultrasound rounds within critical care, but of course, we invite all specialties because there's more than enough overlap. But generally try to have some kind of theme through the year. And this year, I think it's just kind of reviewing much of the core content. So I thought starting with fluid in the pericardium, a very common concern expressed, and one that's frankly that's pretty easily found, but it doesn't always matter. And I think that's kind of the point I want to get at here is, when does it really matter? That's what Rex says, is it matters when it's bad. And yeah, that is certainly true. But sometimes a patient in shock, it can be hard to tell if it's the effusion or if it's something else that you're just horribly missing. So the goal for today is to appraise a select number of challenging echo findings to aid in the detection of a clinically relevant effusion, and just trying to approach some level of diagnostic uncertainty and trying to resolve confusion, and integrating your findings of bedside physiology with clinical exam findings and kind of putting it all together. I think that's really where the power lies, not necessarily in focusing strictly on the ultrasound findings. So these are all real cases. Of course, their identities and ages have been kind of obscured. That way they can identify, but they are all real cases. So first of all, we have a 66-year-old male. He presents to the ED with shortness of breath and the lower respiratory tract symptoms, so fever and cough. So chest X-ray shows a clear right lobe consolidation, and he's got empiric antibodies for acute pneumonia. Early on, he's hypotensive, despite 2 liters of fluid. The plan is to keep really giving IV fluids till blood pressure settles out. And there's no really defined endpoint. Some people talk about 30 moles per kilo, but really not sure. Just know that he's hypotensive and keep giving fluid. The resident notices an abnormality on the cardiogram and decides to investigate further. I'll take a look at that, and then we'll ask a question next. So just take a gander, take a peek. Keep your findings to yourself, of course, right now, and we'll talk about it on the next slide. Okay, so to answer this question, which is what is the most important finding on ECG, if you pick up your mobile phone or your web browser and put in menti.com, put in the code, then you can answer this skill testing question. Most are saying that it's low voltage. Okay, good. But sinus tach, of course, like to emphasize, both here are present. This patient's heart rate is like around 110, but it is also low voltage. So given the context, it kind of maybe tips your hat. Maybe there's something else going on here. So here's the first image that the resident acquires. Okay, so can anyone here tell me what view this is? Parasternal lung axis, awesome. If I point to here, what am I pointing at? About right here? Yeah. It's kind of funny. This is often called RV in reference materials, but technically it's the RVOT because it kind of crosses the aorta. Yeah. And does anyone here, actually, you know what? Before we ask that next question, we have a skill testing question. Because this is just a free text response. What needs to be done here to help better understand the cardiac anatomy? So for those who first of all, I'd like a better view of the LV apex. So what do you think about the LV apex from this view? Do we typically focus on the apex in this view at all? No, yeah. So typically from a parasternal view, we're kind of viewing mostly the base of the heart. Like anatomically, our probe corresponds really to the base of the actual heart, which is more in line with the aortic and mitral and tricuspid valves. So we're quite far from the apex. Technically, we don't really care much about the apex in a parasternal view. We mostly focus on the basal and mid portions of the LV. There's a couple of things here a couple of questions about remarks with more depth. And so why more depth? Yeah, so if you're not cautious with your first view in echo, especially doing parasternal imaging, and you don't have proper depth, it's very easy to miss things in the far field, especially pleural and pericardial effusions. You will miss them because you'll notice there that space in the far field, the farthest from the probe, is black. And you might think, oh, there's nothing there. But in fact, black, of course, doesn't mean nothing there. It means that something is there, in fact. probably of the fluid type. I think someone's saying LOL at IVC.
Fat fingers trying to say look.
Oh, indeed. Okay, so I got Fat Fingers McGee over here. Okay. So here we go. Here's that depth.
I need to use my instrument to push the button.
So here we go at depth. So who wants to take a crack at it? And that's online or in person. I see a chat remark here. Oh, Shell. There's also pleural effusion. Okay, here. So look, Shell here's pointed out there's a pleural effusion, right? Is it only a pleural effusion? Yeah, it's pericardial as well, right? You can see that little sliver in front of the aorta. There's dropout right here, probably from a rib. So it's cutting off that fine line. But if you have both pericardial and pleural, then you'll see this fine hypercoic line, because basically that means the pericardium is subtended by fluid on either side. Okay, so that's important. Good. Now I've got to move on here. Measurement, 2.5 centimeters, okay? But technically, the period we measure a pericardial effusion is in diastole. Okay, so we don't measure it distally, because systole is when the cavities are collapsed and it makes the effusion look bigger than it truly is, right? So technically measured diastole. So I can't really tell here, and I'm a little suspicious that this wasn't measured properly because the cavity looks smaller than it should be. So I'd be a little suspicious of this measurement. But anyways, that's kind of it there. So again, she measured in diastole. Now, if we're looking at this heart here, okay, do we see anything, like if we're really worried about tamponade, do we see anything here that would make us worried? This view actually is instructive for RV diastolic collapse, okay? But you're going to be really careful, because the RV should collapse during another phase of the cardiac cycle, which is systole, right? So that's always the hard part is if you have an ECG gate, which means a concurrent ECG, that's very helpful.
Yeah, or just slowing it
Yeah,
down.
if you slow it down during valve closure, okay, so going forward now, watch as the valve, because what you want to see is compression when the valve is open, right? That's diastole. So watch as the valve opens. See if this is better. No, it only collapses during systole, right? So that's reassuring. Here's an apical four-chamber view. Now we're going to refrain from commenting until the next slide, because I want to make it awkward like that. Right? What kind of view is this? What view is this? Apical four-chamber. Perfect. Yeah, we see all four chambers really nicely. It kind of occasionally brings in the fifth chamber, quote unquote, the aortic valve. So it's not perfectly on axis, but that's fine. Often when you have bigger effusions, the heart swings a bit, so it's hard to get one static view of structures. Here's the question, and let's see if it works. You look at this apical four-chamber view and you suspect tamponade. What finding is shown here that suggests this suspicion is incorrect? There's scales at the bottom. Okay, good. So we have 6 responding so far. So most people are saying that the RV, RA, and LV size are all pretty open. Okay, and I agree. That's actually very reassuring. Typically, if you have evidence of tamponade on an echo, you will see the chambers are relatively collapsed. Okay, the RA and RV should be relatively small. Okay, and we'll talk about when they're small, but typically they're actually hard to see. Like you'll see in really frank tamponade, you're kind of like struggling to even find the RV because it's so collapsed, or it's so much smaller that cavity volume is tiny. Okay, until they inspire, and transiently it will actually get bigger when they inspire. Okay, and then it will actually decompress when they breathe out. Okay, so that's just because of the obstructed inflow nature of tamponade, because it basically causes this gradient, which doesn't really favor filling. So the RV will actually dilate a little bit. Then as you expire, it gets the blood out. Okay, now we see this. It's your IVC, as Dr. Cowan here has so kindly pointed out. We need to look at the IVC. Dr. Cowan, what do you think? This IVC, is it reassuring or is it?
This is pretty reassuring.
What's reassuring about it?
Actually, can you play it once more?
Besides it being an IVC.
Yeah, we've got there's enough variability there. It should be pleural and not collapsing.
Yeah.
In a tamponade. And so the fact that we're seeing variation reassures me that there is a tamponade physiology.
I would say it's probably a really small variation because there is some translational movement. You can tell it kind of, it's not exactly in the same plane, right? But it's not big. Okay, it's not plethoric, and plethoric being like greater than 2.1, 2.2 centimeters, like very large. Okay, you guys will, I'll show you images of truly plethoric IVCs, which give you a sense of how things really look. But yeah, so, but I would say this is kind of neither here nor there. It kind of doesn't, it's not really that confirmatory, but it's also doesn't tell you that it's not the problem.
Because if it's collapsing, that pretty much rules out tamponade. But
Yeah. Okay, start the Menti here. You're all going to be assigned icons here, yeah. See, there's pericardial here. Okay, good. So there's some people online. Sorry, I missed your comments there. Feel free to scream it out. Okay, we'll start the quiz. Here we go. Do you think this patient has tamponade? Wow, fastest Mentimeter in the history of Mentimeter. I don't know. That's pretty fast. That's pretty good. So yeah, no, they don't have tamponade. Okay, and yes, they were hypotensive. We heard from the start. Okay. Now you could argue that maybe if this is post 2 liters of fluid, maybe they did have a bit of tamponade before, right? Because once you give fluid, you do change the kind of intracavitary pressures in the RV and LV, right? So could they have been in tamponade before they were given fluid? Maybe, but maybe you've reversed it, okay? And it's pretty common to see patients that have tamponade that get fluids, okay, that rapidly reverse, permitting. There's not a couple caveats there. For example, in trauma, if you were stabbed in the chest and you had tamponade and you had a big hole in your LV or probably more like the RV, then that may not be the way to fix that particular problem. Obviously. So yeah, this is a 66-year-old guy who basically acquired pneumonia, was hypotensive, and based on ECG findings of low voltage, had an echo done. And it reveals normal ventricular function and a pericardial effusion. There's really no clear manifestation to your intraventricular dependence or tamponade on echo. So we didn't see really evidence of that, periodically dilated RV or even a small RV, for example. We just saw what looks like a normally open RA and RV. The one major caveat to that is that if you have pre-existing pulmonary hypertension or right ventricular hypertrophy, okay, then that can make compression on the right side less likely to happen. Okay, so if they have a really thick RV, it may not compress. The whole reason why the right side compresses is because of the pressures are a little bit lower than the left side, but mostly because of the wall thickness. Okay, wall thickness is much less on the right than the left. So obviously, if the wall is thicker on the right, then it may not compress. In fact, in certain cases, you may actually see compression of the left ventricle before you see compression of the right. But once you see compression of the left ventricle, you can imagine you're not far from having major problems, which is mostly death.
Yeah.
To be clear, it's very bad to see compression of the left ventricle during tamponade.
Yeah. There'd be a needle going in there.
Yeah. I'll also add too that people often, like I've heard the comment like, oh, you don't really need the parasternal long axis view for a pericardial effusion. But the truth is that you can actually have tamponade physiology from a pleural effusion. Okay.
Yeah.
Yeah.
Yeah. Why is it going to be collapsing? I don't understand.
Yeah. Yeah.
Anything that obstructs flow will cause tamponade.
We have Dr. Townsend here beside me. He was just saying, so Dr. Townsend, for those online, works in cardiovascular ICU, and he's just saying that, you can have these patients who have large pleural effusions that can cause compression of the RV, and it can stump folks, including our cardiologist friends, because it's a little bit atypical. But certainly there is a ton of cases reported that look at pleural effusions and compression on the RV. So yeah, we started this case with some low voltage in the limb lead, which can be seen obviously more than just tamponade. So again, in big pleural effusions, it can be seen. So just FYI, but it is, a point of interest, this whole idea of low voltage. Again, then there's some sinus tach as well. So we know that sinus tach is a helpful sign in tamponade. Another point to focus on here, just remember you need to adjust for depth. It's very easy to miss things in the far field. But that first view, I generally tell everybody to hit about 20, 22 centimeters to make sure they can see everything that's below the heart. Okay, this is And this view is really helpful. As you can see here, there's actually both pleural and pericardial. Agree. And there are certain cases we've had where the echo doesn't say tamponade, but clinically they're acting like it, and we just push to get it drained because it's just sometimes echo does not answer all the questions, and for a variety of reasons like intrapleural pressures and positive pressure ventilation, they can kind of change the hemodynamics of a normal response to tamponade. So this just shows, you know, the difference between what it looks like when someone has pericardium on the left and pleural on the right. Okay, pericardial on the left, you can see goes enter to the thoracic aorta, and on the right goes behind. Okay, and obviously this does not exclude having both, which we saw start this case. Here's an example of just some lung floating in there in the pleural space, right?
Yeah.
And occasionally you'll actually see this all being consolidation if you have a really dense basal consolidation. Often I've seen this in like strep pneumonia, or patients have really, really dense pneumonia, and you see this just massive area of consolidation below the heart.
You also get mirror image artifact in that space. What's the conditions that allows for that to happen?
So if you think about anywhere where there's mirror image, you have a boundary that has a large difference in acoustic impedance, right? So in this case, you probably wouldn't get a mirror image artifact. Okay, the big reason why is you have tissue to fluid. Okay, but in a normal heart, where this should be air behind the heart, like the lung, then you have tissue air. We get much more of that. Those interfaces where you have a strong reflector that's bounded by air means that you have a high amount of reflection.
Yeah, I've
Case.
actually seen cases where you see the mirror image of the left ventricle where the lung should be.
Yeah.
That's cool.
And for those who are online, including you, Irene, if anyone wants to chime in, certainly more than enough people on here who have a high degree of expertise. So if anyone wants to add, please chime in. I'm a chatterbox. So
No, what you described was perfect.
That was exactly, you know, if it's fluid in there, you're unlikely to get a mirror image artifact, but you will if it's air on the other end. And you do see it a lot. You'll see a mitral valve flapping away on the other side of the pericardium.
yeah, awesome. Yeah, it's a really it's a really interesting vantage point to have. Also, occasionally, if you have a big hemothorax with clot, you'll see this could in fact be clot just lingering around in the chest. So just be aware that sometimes this space can look kind of like lung, but in fact, it could be a massive hemothorax. And here's just, you know, often it's like, is there a pleural effusion on the personal lung axis? Well, you can also just look on the left side because, you know, our skill sets go beyond just looking at the heart. And this is just a list of different kinds of problems we see presenting as tamponade physiology, pleural effusions. In fact, a couple of case reports of tense ascites causing cardiac tamponade physiology.
There's not enough blood coming back to fill that, so you get that.
Obstructed inflow, exactly. Yeah, and especially when you add patients with cirrhosis will often have both tense ascites and pleural effusions, like hepatic hydrothoraces, whether it's unilateral or bilateral, and can have a really reduced pressure in their chest. In fact, we had a lady with abdominal compartment syndrome who was getting a TIPS that bled, and so we drained her, and she still had a high abdominal compartment pressure, and so we actually drained her right chest. Took off 3 liters off her right pleural effusion, and that lowered her intra-abdominal pressures. Yeah. So I know that's kind of a bit of a more, I don't know, a bit of an odd case, but just to highlight that there can be variants of this. And chamber collapse is just a really important concept to understand. Okay, and just to really understand when the chamber collapses. So the RV should collapse in systole. Okay, the RA should mostly collapse in diastole because that's when the RA is emptying. Okay, however, we talk about that chamber collapse of the right atrium. In tamponade, it's more prominent at the end of diastole and then through systole. Okay, so as that valve is about to close, that's when the chamber collapses in tamponade. And when the valve's closed, and that's during systole, that's also when the chamber's collapsing. And the longer that right atrium's collapsed during systole, the more likely it's tamponade. Okay, but again, this gets into really fine detail about chamber collapse, but I'll just emphasize that difference between diastole and systole. Okay, next case, Miss HS. 6-7-year-old male. Actually, technically it's a female because it's Miss HS, but who knows? Basically, end-stage renal disease on dialysis, immediate communicable pneumonia, undergoes dialysis for 4 liters, for suspected overload, because, you know, they're being aggressive, and basically has progressive hypotension. I suspect many of you know where this is going. Let's answer this question, the skill testing question. I'll start Menti. What do you see here which may explain this presentation? Good. So I see here that there's a couple of things identified, pericardial effusions being one, and also the LV being very poorly functioning. And I completely agree. And I think it can be really hard sometimes to separate what the leading problem is. But finding this view means that you have a couple threads to follow. Okay. And for those who are learning ultrasound initially, it can be extremely hard to keep those two things in your mind, that maybe it's this, or maybe it's that, or maybe it's none of those things. But certainly in this image makes you think it's one of these problems. Good. So obviously what we see here, we see a large anechoic collection, which looks like it's mostly anterior to thoracic aorta. It's pretty sharp, right? It doesn't go around the aorta. So it's most certainly pericardial. And then if you look here in the near field, you can see that there's some fat plus a bit of an anechoic space. And yeah, the LV function is super poor, okay? Very little thickening in the anteroseptal wall and infralateral wall. In fact, this is almost akinetic because it barely moves. I mean, it wobbles, but it doesn't really thicken.
It floats around.
It floats around, yeah. So this is a really poorly functioning heart. And for those who live and die by EPSS, obviously this anterior leaflet it's not really doing a whole lot, right? It's not coming close to the septum, which means that diastolic filling is probably not very strong for one. It's probably reduced. Plus the heart's kind of big, right? The LV is kind of a bit generously sized, right? And when the heart is generously sized, it actually can change how that valve looks. Okay, there's less leaflet excursion. Here we go. Okay. What do we see here? Who wants to, how about online? Online, who wants to take a stab at it? You can do no wrong, trust me. I'm gonna let you call it amyloid, because it's not amyloid. Shell, if you were landing, seeing this patient in a rural site and they're looking hypotensive, what would you do with your team?
Yeah, so you see that effusion here. You're looking at the PAP level. So your mid-ventricular looking at the PAPs, and it's barely moving. It's pretty akinetic, just kind of correlating to what we saw on the parasternal long axis. It's hard to be able to see the septum on the side there. It's kind of blacked out to be able to see the septum.
Yep.
Some
drop out there, probably from a rib.
And then what was your question? What do we want to do?
No, just basically what do you see? Yeah, that's it.
Yeah.
And a big pericardial effusion, right?
Yeah.
Circumferential, big, fairly anechoic space, fairly uniform. You found a pericardial effusion. What is the most reliable clinical exam sign? Sinus tach, muffled heart sounds, pulsus paradoxus, or elevated JVP? Right out of the gates, pulsus paradoxus is winning.
Is that sensitivity or like specific or sensitive that we can?
It's actually, yeah, it is both. I mean, it's often cited, for example, with asthma exacerbations and tension pneumothoraces. But to be honest, those diagnoses are kind of like a whole different diagnostic class. So
that's if you're looking at it with an art line in, the most sensitive and specific thing that we have, the left ventricle is empty, is actually pulses on an art line.
Yep.
But it doesn't tell you why the left ventricle is empty. It just tells you the left ventricle is empty.
Yeah.
All those reasons that Brian just described are reasons why the left ventricle is empty.
Yes, exactly. So pulsus paradoxus is the most reliable sign. It is certainly the most specific. In fact, if I get a phone call and the question is tamponade, my first question is, what is their pulsus? Okay, unless they were stabbed in the chest. Back to the trauma problem. But typically, this is the most reliable sign. In fact, pulsus is actually what corresponds to what we should be looking for in echo. Okay, because that pulsus, so as you guys may know, pulsus paradoxus is not a paradox, right? When you breathe in, we have ventricular interdependence. So when you breathe in, okay, you get more blood flow to your right side transiently, and that reduces filling on the left side. So in fact, typically your blood pressure, stomach pressure reduces a small bit during inspiration and inspiration. Okay, but during pulsus, we have exaggerated inspiratory reduction in pressure. In fact, the whole story is because basically on clinical exam, someone with tamponade, if you felt their radial pulse, when they breathed in, as they breathed in, their pulse went away. because systolic pressure there was an exaggerated drop. That's why it's called paradoxus, because the pulse was gone and they were still alive. Okay, but it's not really a paradox at all. Okay, just that it's exaggerated for reduction because you've basically emphasized intraventricular dependence because you have pericardial constraint. The pericardium can't really adjust to allow increased filling, whereas a normal pericardium can. It can adjust for some degree of stretch during inspiration. This is from JAMA 2007, just showing for those who want to dive into the details, this is where all the data is from. Looking at, this is the sensitivity of the physical exam. So pulses, fluid sensitivity, 82%. And then tachycardia is right up there. Certainly, that's another key question that I would want to know is, are they tachycardic? Although this is not present in all patients to be aware of. And then looking at just pulse paradox itself. So when looked at this alone in terms of the sensitivity specificity, it's greater than 12 is actually 98% sensitive and 83% specific. Okay, but you can tell that specificity drops when it's not that high. Okay, just like everything else, when it's really positive, it's much more likely. So very strong liquid ratio as well if you find it. So yeah, pulse paradoxus is one of the more reliable signs. And especially as the echo correlates of tamponade are kind of like the highest fruit on the tree, sometimes the forbidden fruit, using spectral Doppler. So we'll talk about that. So this is the same patient, okay? I promise you, this is not altered. This is the exact same patient. You're thinking to yourself, yeah, that LV is not functioning well, but there's something else going on here. Right? Yeah, okay. What is the most concerning finding? And there are actually two correct answers here. I couldn't do select all that apply. They just changed the settings on this. So you can only pick one, but that's okay. Variety of answers here, a plethora of answers. Okay, so let's start with the RV. Yeah, collapse of RV during diastole, that's a really important one. This RV is very small, okay? As I talked about before, generally if they have tamponade physiology, excluding pulmonary hypertension, their RV should be pretty small, okay? It's not a big RV. There's no ECG gating here, so you can't say exactly what phase it is in, but you can tell it's a very, very small RV, okay? And the next one is collapse of the RA during systole. So just recall that the RA should have some collapse during diastole, because that's how the RA empties, right? But during late diastole, that's when we talk about, that's when the onset, we think more likely to be tamponade, because that's when the pressure is at its lowest. But as it extends from late diastole through systole, that's when the RA compresses, okay, in tamponade, because that's when the pressure is very low in the right atrium. Does that make sense? So here's the subcostal four-chamber view. You can see like really struggling to find that RV there, and the RA is really compressed. And like, I have seen cases where I can barely make out the RA-RV because it's so compressed. You just can't see it. But very large effusion here, okay, and you can tell depth marker wise, you know, this is like a 3 to 3.5 centimeter effusion here in this inferior portion. Yeah, it's a nice picture, right?
Yeah.